Hello, I'd like to welcome everybody to this presentation. We're doing this on behalf of the VExUS committee, which is Focus Ultrasound in Intensive Care, as you can see here. And there's myself and Segun and I, who are both members of the VExUS committee. And we'd like to run through a subject that is certainly coming to the fore at the moment within ultrasound, and that is venous excess ultrasound, how to do it, what it's about, how to assess it, and how it can be useful for your patients. So if we take our average patient and we take our phased array probe, for example, place it into a modified subcostal zone, we're wanting to focus in on the liver and obviously the hepatic vein, the portal venous system. So if we just strip things down, an anatomical view will show us these structures underlying. And we'll zoom further in and you can see that you've got the IVC in view here and the main branch is coming off. We'll just colour those up, strip away everything on the side, and there you have, at the bottom left is the right portal vein, and the left portal veins coming off, they're the inferior sections, and superior to those come the hepatic veins. You've got your right, your left, and your intermediate hepatic veins. So the probe position, with a bit of alteration, we'll be looking at all of those vessels together, and we're focusing again on portal and hepatic vein flows with Doppler. So normal hepatic vein flow looks something like this. We get our subcostal view of the liver. You can see the vessels highlighted nicely, colour them in, strip them off, and you can see you've got your IVC and your hepatic branches coming through. If we place a Doppler gate down through the middle as perpendicular as we can to hepatic venous flow, we get a waveform that looks like this. Now you get an upstroke, which is atrial systole, and then we've got the important ventricular sections of systole and diastole. Now focus on those S and Ds below the curve, because these are important later on, as we'll mention. Hepatic vein flow patterns, there are various of these. Now again, if we get our Doppler window, place the gate appropriately into the center, we can get various different waveforms. Now, as right atrial pressure increases, those waveforms will change. This is where things become important as far as venous excess goes. And if we look again at this, you can see that there are changes in pattern as right atrial pressure increases. The main things to note are that the systolic side of the waveform starts to diminish and reverse in direction. So by the time we're getting to the bottom with high right atrial pressure, i.e. venous congestion, we'll see systolic reversal. You'll also note that the diastolic component begins to increase quite substantially as we flow from top to bottom, i.e. less to greater right atrial pressure, i.e. venous excess. Looking at the hepatic portal flow section, place the Doppler gate again in the middle of that echogenic walled structure, and we will get a very phasic pattern of flow, which you can see here. Strip everything down there and you can just see what we're looking at. There's a gallbladder at the bottom and the main portal vein flow. If we want to show you the curve itself, again, phasic flow above the baseline, and it's hepatopetal, which means towards the liver. Again, this is important for venous excess, and I'll show you the different flow patterns with right atrial pressure increases as we did before with venous. Top phasic form is normal. The midsection here shows it's beginning to become pulsatile, and then it actually becomes pulsatile and below the baseline and reverses itself down. So to and fro, dipping below the baseline is severe venous excess. Showing all of this together, here's a clinical example. We've got a dilated plethoric IVC, dilated LV and RV, as you can see on long axis, short axis, and again on four-chamber view, we've got dilated RV. So there's signs of venous excess, dilated hepatic vessels, and again, portal venous pulsatility, whereby it's not phasic anymore, and reversal of systolic flow on the hepatic side of things. So these are all signs of venous excess. So Segun is now going to come in and explain a bit more about VExUS scoring, what it is and why it's useful to us. So take it from here, Segun. Thank you.
Hello, everyone. Can you move on to the next slide, please, Johnny?
Yeah.
So what we're going to talk about is what normal flow looks like. So the concept behind the venous excess scoring or VExUS scoring is basically about giving people a way, or giving everybody a way to kind of grade the abnormalities or lack of abnormalities that they see. And this will go from clearly a normal scan to a severely abnormal scan. And so if we start by looking at the normal, so Johnny's done a great job of going through what the normal hepatic venous Doppler looks like. And it's worth mentioning that the VExUS score actually comprises four things. Comprises your IVC, your hepatic vein, your portal vein, and your renal arterial / venous Doppler. So normal flow should look like what Johnny's described. So you've got a really nice hepatic venous Doppler flow there that shows your normal S wave and D wave with a normal atrial reversal wave. You've got normal phasic portal venous Doppler, which is just a nice, pretty straightforward flow with velocities about 20 centimeters per second and gentle variation with respiratory with breathing. And then if you look at intrarenal arterial and venous flow, your arterial flow should be normal with something and with a measure called the resistive index, which is a measure of your systolic and a comparison of your systolic and diastolic flow. Your resistive index should be normal. But more interestingly, if you look below the baseline of your intrarenal venous flow, and we'll talk about how to do this in a little bit. If you look below the baseline, that actually shows you your venous flow, and your venous flow in a normal kidney should be continuous with a little bit of respiraphasic variation, a little bit like your portal venous flow. So now when we go on to describe what are mild abnormalities, again, we've left out the IVC here because the first thing that you should be looking for that's abnormal in your VExUS score should be your IVC. And a normal IVC should be less than 2 centimeters and have some respiratory variation. Once it's more than 2 centimeters, they need to look downstream at your hepatic and portal veins at abnormalities. So when you start getting mild abnormalities, the first thing you'll notice is a change in your systolic and diastolic ratio and your hepatic venous flow. And your systolic, and you'll get blunting of your systolic flow and an increase or a visual, what looks like a visual increase in your diastolic flow. And this is as a result, this is a result of lots of different things, but it's essentially a change it's gradually increasing venous pressure, which is reducing the pressure gradient in terms of systolic flow transversing down the hepatic veins. Whereas if you look at the portal venous flow, your portal venous flow will start to noticeably become more pulsatile, and you start to get much more variability. And I believe the cutoff that Philippe Rolla and Andre have described is about 30%. So once you start to see a change in your baseline velocity and your peak velocity of your portal venous Doppler of more than 30%, that is concerning for a mildly abnormal, that starts to be a mildly abnormal portal venous flow. And your intrarenal venous flow is quite interesting. So what you start to get is a separation of your intrarenal venous flow, and this is actually been described as something called the renal the venous impedance index, and where you can actually just divide the peak in your systolic and diastolic component of flow. So if you look below the baseline on this image that Johnny's drawn, what you can actually see is that rather than being a continuous flow at the base below the baseline, you've actually now got separate peaks. And if you look, you've got a peak that tallies with the systolic peak of the renal arterial flow. You've got a second peak that tallies with the diastolic component of flow. We call this biphasic flow, and that's a mild abnormality of intrarenal venous flow, and that increases your VExUS score. And this is somewhere between, so this will give you a mildly abnormal VExUS score. Now we come to the severe abnormalities that are associated with significant congestion. So again, your IVC would be more than 2 centimeters, and by this time you should have no respiratory variation because you should be completely congested. By this point in time as well, you've got such severe venous congestion and such high pressures being transmitted down the whole system that you've actually now got systolic flow reversal of hepatic flow. And this would tally again with a very high CVP, giant V waves on your CVP. And Johnny's got a lovely example there showing systolic flow reversal. If you're not sure about systolic flow reversal, you should think about sticking an ECG on so you can actually get the timing of when your systole and diastole is. Moving on to portal venous flow. By the time you get severe abnormalities, your portal venous Doppler and the difference between your systolic and diastolic peaks will be more than 50%. And in really, really bad cases, your diastolic flow will actually go below the baseline. So you actually get portal venous flow reversal. That's a sign of very, very severe congestion. Your intrarenal venous Doppler also changes in itself. And what you'll end up with here is you'll see two things. So first of all, you'll almost, by this point, once you get severe congestion, you'll almost certainly have an acute kidney injury, and that'll be reflected in the fact that your renal resistive index will be above 0.8. So that will be the difference. Your systolic flow minus your systolic peak velocity minus your diastolic peak velocity divided by your systolic peak velocity will be a number that's more than 0.8, suggesting that you've got significant abnormalities of renal arterial flow. But also looking at your renal venous flow, there will usually just be one peak left, and so this we call monophasic flow, and it's a single peak just in diastole, and that essentially what you're seeing is very, very similar to you're essentially seeing systolic flow reversal of your renal venous flow. So your systolic wave is no longer below the baseline; it's actually above the baseline. So all you're seeing is a little diastolic peak below the baseline. And so putting that all together, you can actually look at all these abnormalities, and the idea is by scanning through distally from the IVC down to your renal vessels, you can then get the series of abnormalities, and that allows you to categorize your patient into what you consider mild, moderate, or severe congestion. And this scoring system has actually been devised and recently been validated by a group from Montreal. And I think Johnny should have a link to the paper next, if I remember correctly. There it is. So it's by my friends William, Phil, Corbin, and Andre Deneau, who are amongst guys who all did the work. What they've done is they've looked at a whole bunch of patients post cardiac surgery, and they've matched up their venous congestion, all of the abnormalities of venous congestion of venous flow and venous congestion, and tried to map it to their risk of acute kidney injury. And they came up with multiple scoring systems, and the score that they validated. So if you go on to the next slide, Johnny, I think so. Johnny actually shows the different ways that they tried to grade it. So they actually came up with 5 different grading systems, which they describe as VExUS A, VExUS B, and VExUS C. So if you keep clicking through, you should be able to see all the different aspects of the different VExUS scoring. And what they tried to do was try to match the severity of flow to the ability to predict an acute kidney injury. And if you look at the different scoring systems that they have there, what they try to do was they try to break it down and try to include mild or severe abnormalities. But what they found was that the VExUS C score, which is the one on the extreme right, it was the most predictive of acute kidney injury post cardiac surgery. So that means, so this should be the score that we're all officially using for scoring our VExUS patients at the moment. So if you have a normal IVC and everything else is fine, you're grade 0. That's not, so you're VExUS negative. Once your IVC is dilated with no respiratory variation, that gives you a VExUS grade 1. And VExUS grade 1 now includes mild abnormalities in any of the other downstream variables. So if you've got SD reversal, or you've got biphasic flow, or you've got biphasic flow in the kidneys, that still counts as a grade 1 VExUS. Your VExUS grading goes up to grade 2 once you have one severe abnormality in either your portal or renal venous flow. And VExUS grade 3 is when you've got the full house of severe abnormalities. So dilated IVC, hepatic venous flow reversal, severe portal venous pulsatility, and monophasic renal venous flow. And that VExUS C score is most specific for predicting acute kidney injury in their cohort of post-cardiac surgical patients. I believe there's another paper coming out to validate it in sepsis, and hopefully be a paper coming out to validate it in heart failure. The caveats to the VExUS score is that it's not sensitive for renal failure. And that is completely understandable, seeing that post-cardiac renal failure can be caused by a bazillion other things aside from venous congestion. However, what they've proven is that if you're congested, you're almost certainly going to have an acute kidney injury, and therefore that shows that this score is predictive is associated with adverse patient outcomes.